Welcome, everyone, to another Interhab 2023 virtual Power Up conference session. I am excited to have two special guests with us today to talk about, I think, what's going to be a really cool, from what they've told me, topic that will provide a lot of insight for all of our attendees. So welcome, Heather. Welcome, Doug. I'm going to let you guys do formal introductions for yourselves. And thank you so much for being here.
All right, Heather, take it away.
Sure. Thank you guys for coming today. My name is Heather Pace. I'm the Service Access Manager here for Sedgwick County CDDO. It means I oversee intake, eligibility, and assessment, as well as complex case here for Sedgwick County CDDO. Doug, I'll kick it over to you.
Thanks, Heather. I'm Doug Golub, and it is so nice to be here virtually at Interhab. We partner with SCDDO for their electronic records. And it's through those records that we have an opportunity today to use some new technologies specifically related to artificial intelligence and natural language processing, and show some important outcomes and improvements for the people we support. We are going to start off today by giving an overview of the incredible and critical work that Sedgwick County DDO does. We'll also be talking about individuals that are duly diagnosed with intellectual disabilities and also other psychiatric diagnoses and what this means for receiving services and supports. Then we get into sentiment analysis and artificial intelligence and machine learning, and what some of the data can tell us that has been there all along, but the technology hasn't been until now. And we'll look at some stories of people that are supported by SCDDO and other people that are on the wait list waiting to be supported, and what artificial intelligence can tell us to make better decisions. And we will bring it all together. Everything that you see in today's presentation has been de-identified. We've changed the names and altered the stories to preserve the privacy of each of the individuals, but these are all based on true stories. We've used machine learning and artificial intelligence in this presentation, and it's in its very early stages for human services. So the results are not intended for clinical decision support or HR management or any other purpose other than to illustrate and raise the bar on what could be possible within the next decade, or at least in the months and years ahead. Also, all of the data that we've used for artificial intelligence has been done in a lab. It has not accessed the internet. It has not been sent to any other AI vendors, and the data has been deleted as soon as it was done. So there's full transparency with what was done with the data to make use of best practices, specifically with something as emerging as artificial intelligence.
All right, so let's jump right in here and talk about a little bit of setting the stage, Kansas's Community Developmental Disability Organization model, and specifically Sedgwick County Developmental Disability Organization, or SCDDO. In Kansas, we have a system of 27 different CDDOs across the state of Kansas. Some of those are not-for-profit organizations, others are affiliated with county government. CDDOs in general are responsible for being a single point of entry into the IDD system. They're responsible for working with the person to seek services and get access to those services, as well as referring those people to other agencies if additional supports are needed. And that could be community-based providers. It could be natural occurring providers in the area that they could get additional supports. And also CDDOs are responsible for network capacity and quality oversight of the services that are delivered. So here at Sedgwick County CDDO, we're a little bit different than a lot of CDDOs across the state. Our catchment area only includes Sedgwick County, but it supports over 2,700 people, which is 18% of the population that receives IDD services in the state of Kansas. The CDDO here in Sedgwick County does not provide any direct services or case management, but we are responsible for all of the following functions. The first is being that single point of access, doing intake and eligibility, trying to help people into the system. We do functional eligibility, or that basis assessment, that level of care assessment reporting, and that we submit people to be put on that waiting list to access services in the future. We provide options counseling, where we let individuals who are funded or individuals seeking services through private pay agreements or other funding resources, that options counseling, let them know all the providers that are open and available to them. We do waiting list management for HCBS, as well as local resources that we have, different funding streams, and ensure that people are on the waiting list and ensure that they maintain their current spot on the waiting list. Some of the resource management that we do includes accessing and then monitoring utilization of those services to ensure that people are getting the most out of their services that they possibly can. We also do a lot of network and capacity management. We identify kind of gaps and holes where maybe we need to try to increase capacity. And then also quality oversight of our local service provider network, where we have approximately 50 providers at any given time here in Sedgwick County. So let's jump in specifically to talking about dual diagnosis and the cohorts of individuals that are supported here in Sedgwick County, because it does look different than what we see across the state and across the country. So nationally, we know that people who experience dual diagnosis, which we define as having a behavioral health diagnosis as well as an intellectual or developmental disability, is a massive concern, and it's a very common condition across the country. We see around 30 to 35% of people with developmental disabilities having that co-occurring mental health concern. However, you'll see on the left here, the pie graph that is there shows here in Sedgwick County, we find that about 46% of our population has a dual diagnosis. And that is a significant increase from what we see nationally. There's a lot of reasons, I believe, for that we're not going to dive into here, but just know that our local network has to look at and manage a lot of different types of individuals than what we see nationally. And that has a huge impact on our local providers, our local network, the individuals that are served, as well as financial implications because of that.
And with that, we're going to take a look at something called sentiment analysis to help us color the entire picture for a person. There's a QR code on the screen. You can play along at home and try out this tool. SCDDO uses Metascan Coordinate as their electronic system of record, meaning that many of the functions that Heather discussed earlier are electronically logged. So there is a lot of narrative text from assessments, activities, incidents, and beyond. And we use that data to help tell a bigger picture and a bigger story using sentiment analysis, basically how positive, how negative, how neutral is each given note. Quick example here, when we take a look at a positive note, here's an example that here's a person who exercised using bike pedals. He was verbally prompted to use the computer to look up his area of interest, and he researched trains. He was verbally prompted to speak clearly. He did. They praised him on a great job, and he said, "I try for you," and he laughed. And so overall, that's a 96% positive statement. That one didn't specifically come from SCDDO, but you get an idea that every paragraph has positive, negative, and neutral, and a compound score. Here's a more negative one. This person arrived at his program on time. He was prompted to be socially appropriate, but he refused. He became frustrated and verbally aggressive towards his staff. He was asked to stop and talk about what was making him upset, but he refused. He became verbally and physically aggressive towards his peer. He was restrained. He eventually calmed down, talked about what upset him. As you can see here, there was some positivity to this statement, but it was overall negative, having a compound score of minus 95% on a scale of minus 100 to plus 100, positive, negative. And we're able to look at a lot of the other notes and documentation and tell a story, and sometimes tell a story before there's a problem, to be able to have interventions as appropriate throughout the course of someone receiving services and supports by using this sentiment tool that previously hadn't been used before because it's newly emerging technology. When we do use the sentiment and study over 13,000 case notes for 2,500 individuals, when we look at the cohort of individuals that everyone that's supported by SCDDO has an intellectual and developmental disability diagnosis. But as we had mentioned, 46% also have one or more psychiatric diagnoses, or what we call a dual diagnosis. When you study on that scale of minus 100 to plus 100% sentiment, plus 100% being the most positive of positive, minus 100% being the most negative of negative, when we study all of the notes for the two different cohorts, we actually see a difference here, where people that have dual diagnosis, there's actually a 4-point difference, where the 4 points lower on average for all of the notes. So the overall sentiment is a little bit lower for our cohort of dually diagnosed, which is probably not unexpected, but just some of the data that we've never really known before, and kind of gets us started on the conversation of what else we can learn.
So let's talk about people with complex needs and some key indicators for the individuals, in the population that we're talking about here with the dual diagnosis. So for purposes of this presentation, let's define that population. Interfering behaviors is defined as somebody who scores a 98 or higher on the functional assessment with a top range of 135 plus on the maladaptive health, and they answer 2 or more of the following 6 questions as true during their functional assessment. The first one being that behaviors prevent this individual from moving to a less restrictive environment. The second is that the individual requires a behavior intervention plan in their day-to-day life. The third is that the person needs an environment that they live in and work in that must be carefully structured in order to prevent any behavior concerns. The next is that the individual requires staff to intervene physically with the person. The next one requires a timeout period at least once a week. That must be a supervised timeout period away from everybody else. And it's rarely used, but it is a form of almost like a punishment, which is why we rarely see that used at all. The last one being that the individual requires one-on-one supervision for program activities, and that's defined as 50% or more of their day every single day. They must have a one-on-one with them at all times in order to prevent behavior concerns from occurring. Digging into this a little bit deeper, we know that individuals that have high medical needs are also very complex and difficult to work with from time to time. And so we want to define what that means that an individual has high medical needs. And that's defined as scoring 9 or higher on the functional assessment health score. And the top end of that range is 15. And it requires that the individual also needs special healthcare procedures. So one of these 4 questions must also be answered as yes, that the individual missed 2 weeks of regular activities due to medical problems in the past year, that the individual was hospitalized overnight for a medical problem, that the individual requires the caregivers to be specially trained in healthcare procedures, or that the individual requires some kind of a special diet planned by a dietitian, nutritionist, or a nurse. So in Sedgwick County, individuals with interfering behaviors or high medical needs, we have 601 of those, or 64% of the HCBS waiting list shows that. Also, 1,059 individuals with interfering behaviors and 836 with high medical needs are currently receiving IDD services. And that does include both HCBS funded as well as state aid funded services as well, to be clear. So we started diving into what are the most common behavioral health diagnoses that we see in Sedgwick County. And so we've ranked those by the 10 that we see the most often. The one that we see the most often, I think, is probably no shock to anybody, is that attention deficit hyperactivity disorder, because it does land in that neurodevelopmental spectrum that we see a lot of our individuals having multiple diagnoses from. Also bipolar disorder, generalized anxiety disorder, major depressive disorder, oppositional defiant disorder, schizophrenia, intermittent explosive disorder, anxiety disorder, post-traumatic stress disorder, and depressive disorder to bring up the number 10 spot. So in order to assist providers in supporting individuals, Kansas does have a system in which they can apply for extraordinary funding. And extraordinary funding is there and available for anybody who does require extraordinary supports to maintain the individual in the community. However, we do find significant concerns and issues with this system of accessing that extraordinary funding. So in Sedgwick County, again, providers received extraordinary funding for only 33 individuals in the year 2022. Only 9 out of 17 agencies providing services that are eligible for EF, and keep in mind, extraordinary funding is only available for licensed services, so that's day and residential. So 9 of 17 agencies that are even eligible for that funding applied in 2022. 8 out of 9 of those agencies that applied for EF had their applications approved, and just 33 individuals, again, crossed 8 agencies, even received that funding. The EF process, we know, includes a lot of paperwork and is very time consuming, as well as it requires the agency to show 1 year of funding loss in order to access that funding. The one person that we did see denied EF funding last year, or in the year 2022, it was determined that the item, that support need, should be funded by the MCO and not ongoing through EF funding, so that was denied. One of the other concerns that we've noticed is that one agency desired had the expressly desire to discontinue with the annual EF application over and over and over for somebody who has severe disabilities. For example, the individual may have a severe medical need that is not likely to improve. And maybe they've been receiving EF funding for the last 5 or 10 years, and yet the agency every single year has to complete all of the paperwork and resubmit to continue that EF funding. If the individual is not likely to improve, it would be preferable to not have to go through the entire application process year after year after year. It becomes a barrier for many agencies to get that EF funding. And the other thing I want to note from 2022 is that we did have one agency request an individual who had EF funding had moved, let's say, residential or day agencies to a new provider. And we wanted that EF funding to be able to transfer to the new provider with that person, because we already know that person requires that high level support. They had a one-on-one staff 24 hours a day. However, that EF funding was not able to transfer with that individual, and the new agency could not even apply for EF funding until they had incurred that 1 year of losses, and then they could apply for the EF funding at that point in time. So a lot of work needs to be done on our EF system in order to be able to provide the level of support that agencies really need to help keep these people safe and support them in the community. We are always looking at capacity issues, but one of the capacity issues that I think is felt all over the state and around the country is capacity issues for people that are dually diagnosed must be addressed. EF funding is a part of that answer. However, as you noted on that last slide, there are so many drawbacks, so many concerns when it comes to that we are trying to support this person as hard as we can, and yet accessing that pot of funding is incredibly difficult. So this is one case example that we had of capacity issues for somebody who had a dual diagnosis that was just so incredibly difficult to serve. We had a young lady who was living in the community and receiving day and residential services in the community, had gone between different providers, and nobody was able to keep her safe. Nobody was able to keep her out of a hospital or out of police interactions, regardless of the multiple providers that were tried here in Sedgwick County. So unfortunately, that individual was moved to a state psychiatric hospital. And upon getting to the state psychiatric hospital, they quickly learned that they had to mechanically restrain her anytime she was out of her room. She was later put in her room and locked in her room for 23 hours a day. And she did have security that had to be stationed outside of her room. She is not safe to move into the community, and with gaps in the system, we could not find any provider across the state that was able to support her, that was willing to accept her. And that is with the CDDO, the TCM, the state, the MCO, everybody looking around, trying their best to try to find a provider who had the skills and the ability in order to take this young woman and help provide her the level of support and care that she needed. We were not able to find that anywhere in the state of Kansas. So we did apply for her to be able to go to the state DD hospital, and she was accepted to the state DD hospital. However, due to the level of violent behavior that she was displaying at the psychiatric hospital, the state DD hospital stated that they could not accept her and move her in to their facility because they could not meet her level of need. So we opened up the search. We started searching around the country. We did find another facility, another hospital institution setting that was able to accept her and support her. But unfortunately, that was not in the state of Kansas. And so this young woman is now living outside of the state of Kansas because we could not meet her needs locally. So the capacity issues are huge and high in the state of Kansas, and trying to find some way to support the individuals and to fund that support is incredibly difficult. So what are we doing about that? Locally here in Sedgwick County, we have done many things over many years, lots of work groups, lots of things going on. One thing I want to highlight here is working to strengthen our direct support workforce. Everybody knows the direct support workforce crisis, and finding staff and maintaining staff are incredibly difficult things to do. So one thing we did was to partner with Wichita State University as well as the National Association for Dual Diagnosis to develop a course of what they call badges, which are quarter or half credit classes that are online and self-paced for direct support professionals to take to up their skills, to learn more about dual diagnosis, to learn more about how to support those individuals. And those badge courses are offered through Wichita State University. The other set of badge courses I did not put on this slide. However, we did also offer a badge course of multiple classes for clinicians to learn about persons with IDD, because we know that they need treatment that's maybe different, maybe needs to be modified from typical therapy or treatment milieux. So we did a series of badge courses as well for clinicians in order to beef up their skills on how to support individuals with IDD as well as that co-occurring mental health diagnosis.
So with that, and thank you so much, Heather, for laying the groundwork for some of the challenges that need to be addressed and the incredibly hard work that SCDDO and so many other partners are out there doing every single day. What can these technology tools do to help? Well, we've all probably been hearing a lot about AI, artificial intelligence, and we use this nifty Google Trends tool to see just how much have we been hearing about it. And what you notice here is that you go back 5 years, starting by about December 2022, the news became a lot more frequent. In fact, 12 times as much week over week, starting in December of 2022 than in the years before that. So artificial intelligence is a really big term, and something we hear a lot about. And now we try to figure out how we can use that to solve some of the challenges that Heather shared with us so well. Why is AI such a big deal now? Well, we've been developing these algorithms and tools for almost 70 years. We have more data in electronic format, especially at SCDDO with their Metascale database than ever before, and we can actually use it to train AI models. Our computers have become a lot more powerful, hopefully more powerful than that computer on the screen. Major technology companies are in a race to develop, test, evaluate, and fine-tune these applications, and tools are actually within our reach. So Roomba is the tool that some of you may remember. It was that vacuum cleaner that could go around your house and pick up some things. It was one of the first AI consumer electronics that actually came into our homes, and clean my screen right now. What it did was it actually went out and tried to understand your room. It learned, these are where the walls are. This is where there's a pile of clothing. There's a table over here. And it actually took all those data points in and it generated a plan for how it was going to go around the room. And if you were lucky, it made it back home again. And so that was the first really artificial intelligence tool that came into our homes. Later on, tools like Waze, Siri, Alexa became really big. But actually, it was this tool called ChatGPT that came out in version 3.5 in December. That's why the news has all gone wild, because we could actually try it and understand what was possible. So, most of us at this point have heard of ChatGPT. If you haven't, then well, now you have after this presentation. What does it stand for? Most of us don't know what it stands for. It stands for Generative Pre-training Transformer. So what AI does is it actually generates something that didn't exist before, like a Roomba generating a plan for how its path was going to move around a room, or like in our cases, for people that are dually diagnosed, to help us to generate some recommendations, pathways, suggested outcomes, diagrams, and charts that otherwise wouldn't have been generated. Something like ChatGPT or generative artificial intelligence, it's different than, say, something like Google. Google goes out and finds something that already exists. It's a search engine. It's not going to find anything that isn't already on the internet. Whereas ChatGPT, it learns like a person and it generates something new each and every time. So when it comes to home and community-based services, there's a lot of exciting opportunities and certainly no shortage of risks when it comes to AI. And it comes in different formats, images and video, right? The AI can be image, it can be video, it can be speech, it can be sound. It can be text and narratives, which is what a lot of what we'll take a look at today. It can also be biometric with what we wear and how it locates where we are. So it's pretty exciting what's coming next. And so we've been calling it assistive technology because it's not necessarily intended to replace anything that a person is doing. It is intended to help augment those supports. For example, some of the opportunities for the future, the way we've all done person-centered planning in the past differs, but there are different tools, for example, mapping and drawing for a given person and using that to help a person communicate their dreams, their activities, what's important to somebody, what's important for somebody. We're used to that. What can AI do a little bit differently for us? Well, we used it in a couple of different ways. One is it can take an entire month's worth of notes, an entire decade's worth of notes, assessments, plans for a person, and learn. It reads a lot faster than we do. So it can actually learn that and read that. It doesn't have the same experience as a DSP or as a support member or as a member of the staff of a CDDO, but it reads faster. And so it can take all that in. And in this particular case, this person is trying out for a show in their day program. And it also happens to be Thanksgiving when we're reading these notes. So there's some activities going on there. Well, it can generate a summary, as you see on the right side of the screen here, very quickly. And this is really helpful with our DSP workforce crisis because we don't have all the time in the world. But it's really important that we don't miss anything important in a person's life, whether it's the traumas that have affected a person's life or different ways that a person communicates what their dreams are. Being able to summarize years worth of notes and give back some of the cliff notes here, just like as you can see on the right side of the screen. This is incredibly powerful and one of the easiest ways AI can make it into the practical use cases of what we do every single day. It also has the ability, and we ask it a question from Charting the Life course, really one of the major themes. What recommendations do we have to help the person develop a vision for a good life, think about what they need to know and do, identify how to develop supports, and discover what it takes to live the life they want to live? Once AI has learned about a person, once it's read the service notes, the summaries, the plans, the assessments, the incidents, and it knows about a person, you can ask it questions like this, and it can come up with some really good recommendations. This will never replace the person-centered planning process because we didn't even ask the person, but it's really helpful. And AI comes with some huge benefits in that some of the suggestions and the recommendations it comes with, like what you see on the screen here, may actually not have some of the biases that we do as members, as individuals that are supported or individuals that are members of a circle of supports. The sky's the limit with AI, and it doesn't have the limitations of lived experience, and it doesn't have some of those biases that may tell us I can or can't do something. AI is going to put it out there anyway, and we can decide. The individual that is supported can decide. So there's three things that we've been doing and we'll be taking a look at today. As mentioned, there's the case summaries, being able to summarize a large amount of notes very quickly. There's sentiment analysis that we'll be talking about, how positive, how negative, where are the inflection points in a person's journey on their graph, and suggestions and recommendations. This is really the next frontier, so that AI can give us ideas that we might not have come up with on our own, for ourselves, for the people that we support, for our staff, and beyond. So this is the QR code again. If you'd like to try it, you can type in some notes and it can actually give you a positive, negative sentiment score. And that's exactly what we did as we study the stories of several people that are supported by SCDDO. And remember, we have de-identified these, so the names have been changed, the stories and the dates have been changed, but they are based on true stories. We are just protecting protected health information. The United States Department of Health and Human Services has put out a 10-year plan for what they hope to see when it comes to some of the outcomes research in a person-centered way. And one of those key areas is using unstructured service notes. This means there's not drop downs, there's not check boxes, it's the narratives. Being able to use those to improve person-centered planning and using AI. And they've put out some pretty good guidelines for how to use this safely. And these are making their way into laws and regulations and best practices. For example, you have to be transparent and actually tell somebody what you did with their data. And as an individual, you have the right to know that you can trust it, that it's not sort of garbage in, garbage out, that it's fair and doesn't come with bias, appropriate, valid, effective, and safe. So some of the best practices are beginning to emerge now in this newly emerging technology that the U.S. Department of Health and Human Services sees as a lot more commonplace by 2029. We didn't have patients to wait that long, so we do this today in 2023. And so we start with some stories.
Awesome. Before we jump deeply into the stories, I think that it's important that we look at and we understand the effects of the very long wait list that we have in Kansas. So right now, according to the Disability Rights Center, or DRC, there's about 4,500 Kansans that are on the IDD waiting list, waiting for those life-sustaining waiver services. Currently, they note that the waiting list is about 10 years. We know that at this point in time, it is about 10 and a half years, pushing up on 11 of a waiting list. And that a lot of people do get services because of a crisis situation, rather than because their spot finally came up on the waiting list. So over 900 of those Kansans that are on that HCBS waiting list are in Sedgwick County. So let's look at those people on the waiting list in Sedgwick County just since 2021. 115 of the just over 1,000 people came off the wait list and were funded for services at the Sedgwick County DDO. At least 31 people were incarcerated while on that waiting list. They needed supports, they cannot access them, and they did get incarcerated during that time. At least 30 of them that we're aware of had documentation of a major hospitalization while they were on the waiting list. At least 6 people, unfortunately, have passed away while on the waiting list for services. And we always say at least, because it's only our numbers are only as good as the information that we get. And as everybody knows, people on the waiting list don't always have access to case management. Either they don't have Medicaid or they can't private pay for that service. And so a lot of people are out there and we do not know their stories. We do not know what's going on with them. And about 11 out of the 115 people that have come off the waiting list here in Sedgwick County came off of the wait list because of a crisis situation that they have gone through in order to gain access to the waiver. So this long wait list can already have dire consequences on the person, on their lives, and on their future. So let's take a deep look into Kevin. We're going to talk about a couple of different stories here. Each one is a little bit different. Each person is a real person, but again, de-identified and changed some of the information to protect their privacy. The first one that we'll look at here is Kevin. Kevin is a 21-year-old African-American male. He has autism, an intellectual disorder, ADHD, and oppositional defiant disorder. And we are only looking at the information that we have on file for him between the years 2020 and 2023. So our first point that we have that we looked at, unfortunately, June 2020, we know that Kevin is in jail and that he has been charged with aggravated robbery. And you can see on the scoring there with the sentiment scores, that's a pretty low score for him. In June 2020, we learned that Kevin is now 18. His mom did not file for guardianship. She did not understand if that was something that she needed to do. And so now we have a young man who's out there with a lot of needs who does not have a guardian in place. And unfortunately, the case manager at that time was not able to keep contact with Kevin. He was very difficult to stay in touch with and had to close out services because they were unable to find him, unable to keep contact with him. So then he's on the waiting list with no service at all, no case management. In November 2020, we hear from Kevin, and he wants help to apply for financial assistance so that he can learn how to drive. That's a very positive note. We're moving in a good direction. Unfortunately, we also hear from him later that month that he accidentally signed up for the wrong Medicaid because there's two different applications. He did not have support at that time that he was doing his Medicaid app, and he got the wrong one. But then we swapped to May 2022. Again, he's on the waiting list, so we do have a long period of time here that we're not talking to him. Where he called to inquire if he could use financial assistance to help move into a new apartment. Very exciting, move into his new apartment. Absolutely, we can help with financial assistance for that. Very cool. But then, unfortunately, he has no support, still on the waiting list. And July 2022, we hear that he is arrested and booked into county jail, really struggling at that point in time. He gets out of county jail. He's on probation, unfortunately not getting IDD supports, the criminal justice system not always understanding how to work with individuals that have an IDD diagnosis, and we see him get arrested again for a probation violation at this time, really struggling. So at last we hear from mom in 2023, and she's inquiring, please, is he coming up on the waiting list? But unfortunately, no. We see that Kevin continues this up and down, in and out of the criminal justice system because he is still on the waiting list, but yet does not meet the definition of crisis in order to come off of the waiting list and get the services that he needs.
So Heather and the team at SCDDO, they know, they have conversations regularly, but it also could be helpful to use some of the data to be able to make the case for services that are necessary. When we study people that have been on the wait list, probably not surprising to anybody, of all the folks that have been on and off and on and off, there were 731 that were on the wait list consistently without coming off it. And we had notes every single year for this 4-year period. And what do you know, when you look at the cohorts over a 4-year period, the average sentiment, the negativity goes up, the positivity is pretty much consistent. But because the negativity is going up, what was an average score for the notes, checking in, seeing what was going on, sometimes being incarcerated, sometimes absolutely nothing. The longer you stay on the wait list, the lower the positivity of the sentiment goes, plus 48%, plus 44%, plus 32%, plus 19%. Still positive scores, but as you can see, the longer people are on the wait list, the less positive their notes and their overall approach and sentiment are. We also have a story here of an individual who came off of the wait list because of a crisis. And so as you can see here from this graph, obviously you want to see a graph that just goes up and up and up and doesn't come down, but that wouldn't be relevant for today's conversation about what we're finding and how we can recommend improvements. So here's a person. He did come off of the wait list because of a crisis. This is a person that accused TCM of abuse and not advocating for him. This is a person that didn't return a phone call, and APS gets involved. This is a person that has accusations that he's being discriminated against, made an APS report, so they investigate the provider, and wants a new assessment, which is absolutely within rights, just to try to see if maybe we can get off of the wait list through a new assessment. And of course, at that point, is frustrated because this person is still going to remain on the wait list, and takes it out a little bit on SCDDO as a result. Person's regressing, needs more support for himself. There's self-harm meds and anxiety, and challenges meeting daily care needs. And this is all happening over the course of 2 weeks here. And APS and SCDDO continue to work on redetermination and maybe trying a different TCM agency. Unfortunately, this person gets arrested, 2 charges of domestic violence and battery with the family. So at crisis and screening at the hospital. Obviously, after that, can't go home, doesn't want to go to a shelter, needs benefits reinstated in case he does get funded, looking at potential nursing facilities for mental health at this point, because I was trying to look under every stone for an opportunity to live the life he chooses. A couple months later, says the provider is denying him supports, says he was verbally assaulted. He actually does come off of the wait list following an APS engagement. So there was certainly a crisis, and came off of the wait list. Supports were sought by Ed, basically saying that some of the supports that he sought violated the policies and regulations with KDADS, the provider, and SCDDO. So there were some challenges there. Contacts DRC, thinks that this is a neglect case. APS reports are filed because he said he was verbally and emotionally abused by the staff. Threatens legal action for severe medical neglect. Providers worried that he's directing some of the anger at the DSPs. Cross systems case conference is scheduled with mental health and IDD to find a way to support Ed better. He's duly diagnosed, and he's again worried that some of this is getting directed at the DSPs. And then the provider that he's living with is looking at evicting him. So this person did come off of the wait list because of a crisis, but due to the needs of the combination of autism, the schizoaffective disorder, the overall needs of the person and the provider network, you can see here that coming off of the wait list is helpful, but it doesn't solve everything. And supporting people that are duly diagnosed certainly is not easy for providers or for the individuals themselves.
All right, we'll look at another case study here. This one is very interesting as well because we're adding some complexity into this case study. So this is an individual who has a co-occurring mental health, as well as a substance use disorder and an IDD diagnosis. So this is a 36-year-old African-American male with IDD and epilepsy, an unspecified psychosis not due to substance abuse, and a psychoactive substance dependence disorder. So let's take a look at what's going on with this individual here, a little all over the place. So this is Bobby. In 2020, he was hospitalized after being hit by a car. He is still hospitalized several months later. He's walking with a walker, trying to learn to eat. He had some significant injuries, and people notice that he's a little bit different, calmer since the accident. Several months later in 2021, we see issues with staffing and medication administration. He's unhappy with his housing. He's paying rent, but he's not staying there. He is homeless by choice at that point in time and really not engaging with supports at that moment. An APS report was filed against the provider because Bobby was not being given his medications. He's continuing to have medical issues. He's not going to the doctor or dentist when he's complaining of pain. But he does have, that substance abuse disorder. There's concerns about drug seeking behavior. And unfortunately, he does end up back in jail at that time. He is in jail for several months, but he's back out again in November of 21. Oh, unfortunately, August comes around, he's back in jail. We get that 3161 that we see come from the state that the services need to close because of incarceration. In October of 22, he's out of jail, but case management closed because we saw voluntary enrollment into the One Care Kansas managed care program. And so he does not have a case manager working with him at this point any longer. Unfortunately, shortly later, he's arrested again for not complying with his bond. And then he gets out of jail, but there's issues with getting his waiver back reinstated because of managed care. That One Care Kansas roll-in, we did assist him in opting out so that he could get that case manager support that he really needed again. We see an incident report that was filed then and late in 2022 that shows that Bobby now has a temporary guardian because he was previously a self-advocate prior to that time due to his hospitalization and his own ongoing concerns with self-care. Then we see in March of this year that his services again close out because he is back in jail. He's released later the same month from jail at that point in time. And we get HCBS services reinstated for him. So we're very excited that things are going to start looking up for Bobby once again. At this point, the state is working with the CDDO and the MCO through some complex casework. They requested a copy of the psych eval. We are very hopeful that we're going to be able to put some things in place for Bobby to help him out. But unfortunately, then we see July of this year that he was booked back in jail for contempt of court, and we kind of are continuing this up and down cycle with Bobby right now.
And we can see from the data, we've always, if you were to ask the case manager, if you were to ask Bobby, if you were to ask anybody involved, they know when things are going well and when they're not. But it's really helpful to have the data in a graphical format, which AI allows us to, it can read it, it can generate, it can do that. And that's particularly helpful in making the case for certain services and certain decisions where it goes from the difference between feeling versus knowing and seeing what might be qualitative in a more quantitative way.
Good. So we wanted to take time here to talk about deploying strategies to engage with people that are dually diagnosed. And AI is one of those things that you can use. There's other strategies, though, that I think are always important to remember and to talk about. That strategies that are used in supporting individuals with dual diagnosis are absolutely as varied as the individuals are. We all know that those responses to the individual should be person-centered, and we try to keep them as absolutely fluid as we possibly can so that they can be changed, updated with any change that we see. As you see with Bobby, things can go good to bad very, very quickly. So we need to be very fluid as a team when working with him. One strategy that we use is a complex staffing. And I think that this is where it's very interesting and where AI has a seat at the table. In a complex case staffing, by the definition that we use here in Sedgwick County, is a team meeting that includes all different providers or agencies, individuals that are engaged with that individual. And I believe this is where AI has a seat at the table as well. So you have the individual, the guardian, we have representatives from the state, the MCO, the medical doctor, we can get them there, behavioral health providers, case managers, CDDO, law enforcement, and literally any other system. And when I conceptualize this, if you take Bobby or you take any client that you're working with, they are the diamond that are in the center of the room. And a diamond has multifacets all the way around it. And everybody from their seat at the table sees that diamond a little bit differently, is looking at a different area of those facets. But if we sit together, all together, and we can all talk about our different points of view and what we're seeing and what we think it needs to happen, we can come up with a very comprehensive plan that looks at the whole person, and AI will help bring a piece of that to the table as well. And it does allow the team to have a group effort when we are working together to work across disciplines and to bring more supports to the table. And then we never leave that table without understanding how changes are going to be communicated with that team so that we can keep everybody informed and up to date with what is going on minute to minute with the individual. So here's some other ideas, things that you can do, things that you want to know about. Know your local resources and develop working relationships. I think that one thing that my career has taught me is that we can set out formal MOUs, memorandums of understanding between providers. We can talk formally how we're going to work together. We can have points of contact, but never, ever, ever underestimate the power of a relationship that you have with somebody at that organization. Know the people that work there, know their faces, let them know your face. That relationship, that individual connection makes a huge difference overall. Don't forget the whole person approach. Medical and dental needs, easily to overlook when you're looking at behaviors. But when you look at the whole person, think about everything that could be coming to play with them. Don't forget your natural supports. Where's the person going in their community? Do they hang out at the gas station? Do they go to a coffee shop? If you get to know the gas station attendants, they could be a great wealth of information and support. And remember that those people in the community that they naturally come in contact with can be a sense of support for the individual, or it can be a trigger for the individual. So bring them in, have them be on your side. Supports do not have to be paid support people. And then, of course, make your documentation systems work for you. This is where I'm so excited to see what AI is going to do for us in the future. Database decision-making is so key. It's so important. It helps us prioritize and focus and reduces that guess, because I'm looking through my own personal lens at Bobby or Ed or any of the other people that we're working with. But AI removes that lens and brings us data. It brings us information. It brings us ideas that we can then discuss and keep the pieces that are good, toss out the pieces that we don't want, and give it a shot and see what happens. So use documentation and systems. Keep an eye on what's going with AI. I think it's going to be a game changer for our field in the future.
Heather, thanks so much. That's amazing. And the stories that you told are so powerful. And, you know, any help we can get to be able to bridge the gaps, better support people, helps everyone in the community. So thank you. As we bring it all together now, we've covered a lot today, but we did spend some good time understanding what the realities are, especially for people who are dually diagnosed, and how artificial intelligence can help us see things through a different lens to be able to stretch our limited resources a little bit further. What's next? We see some exciting new research taking place based on what you've seen today with summaries and sentiment analysis. We see additional tools and learning that are in process right now to help us pick out health diagnosis and key events, to help us detect abuse and neglect, fraud and waste, to help us identify unmet needs, to help us identify transportation needs, to help give us feedback on staff and on programming, to help with employment outcomes, to help with community integration and relationship highlights, and also with housing and food security needs. So with that, we also have AI draw this picture of what we thought AI in Kansas looks like. And this is what AI thinks that AI in Kansas looks like. Thank you for getting our sunflowers correct, AI. And I guess that's a brain. So thank you everybody for your time today. And it's so exciting what's coming in the very, very, very near future. Thank you, everyone.
Fantastic. Thank you both so much for presenting today. Definitely fascinating information, and I am so excited to share it with members across Kansas. Have a great day, everyone.
Thanks, everyone. Thanks, Heather. Thanks, Megan.